that we would love to bring to the table every year. We're really excited to have both Steve and Nathan here. I am going to toss to them to introduce themselves, tell us a little bit about how they know CASA, a little bit about where they work and some of their past work that contributes to the ways of experience and knowledge that they'll be sharing with us. I was telling both Steve and Nathan that throughout the time that we've been getting ready for this continuing education unit, people continually let us know that this is a really big deal. Like, we knew it was a big deal, but we were all so excited, and we're really excited to have them. And so, Steve, do you mind if I start with you? Can you tell us a little bit about who you are, how you heard about CASA, and just some of your work that's kind of led you to this place?
Sure. So thank you guys very much for this invitation. So my name is Steve Holtzford, and for many years I was an ER doctor at Delnor since 1998, and just recently sort of went to part-time in the ER to really focus most of my attention in addiction. And so I was practicing addiction, and then I took the addiction board. So now I'm board certified in addiction medicine as well, and really spend most of my time in doing addiction work and in a few different areas. I'm the medical director of the new clinic, of the new residential center out in Northwest St. Charles, RCA. I work with Nate at Lighthouse Recovery, and I also, a few hours a week, I do opioid use disorder treatment through telemedicine, which is obviously during the pandemic a very important modality. So through CASA, my sister, I was telling Maha and Sandy earlier, my sister is a CASA volunteer in Lake County. She retired. She was a history teacher at Libertyville High School, and now she's also an attorney too, so she's perfect for
wow.
it. So she loves it. You know, I'll talk to her and she's like, "Oh, I'm on my way to X to drop off some socks, you know, for my kids." She loves it, and Nate and I both know Warren Matson, who is, I think, a new volunteer or
he's on our children's ambassador panel.
Gotcha. So we love Warren, and maybe a decade ago, a good friend of mine, Pat Malloy, who's since moved to Indianapolis, went through CASA training and was a CASA volunteer. So you guys do amazing work, and I've been to CASA fundraisers, just a wonderful organization, and I appreciate this very much and look forward to speaking today.
That's awesome. And I see our executive director's on as well, Gloria. Did you want to say a few words before I introduce Nathan?
Well, and thank you, Dr. Holtzford. I mean, obviously, we've known you for several years in the community, and all that you do for so many of us nonprofits. It's just really nice to see you. And when I heard that, we're able to get you to present today, I was so happy and thrilled. So I know we all have a lot to learn from you, and just appreciate you being here.
Thank you, Gloria. Good to see you.
You too.
Thank you, Gloria.
Thanks.
Nathan, you're up. We're glad to have you here as well. We don't always have the privilege of being able to have two presenters who are immersed in a specific field or expertise. And so we're really excited to get to know you as well and hear what you have to say. Do you mind telling us a little bit about how you heard about CASA, the work that you do, and what's led you here?
Sure. So thank you for having me. I really appreciate it. As Steve said, we work together at Lighthouse. He's the medical director of Lighthouse Recovery. We've been working together for a few years now. Lighthouse was started by Marty Kiefer and I about 5 years ago, and we're an intensive outpatient substance use treatment program located in St. Charles. Prior to doing this work, I was a juvenile probation officer in DuPage County for about a decade. And before that, I was a counselor for the Illinois Department of Corrections for a few years out at St. Charles, out of the prison, the boys' home out there. And so I've been involved in the system for 16, 17 years now. And so my work with CASA has been kind of widespread. In addition to actually working with CASA when I was a juvenile PO and when I was a probation officer in DuPage, my mother-in-law is Judge Linda Davenport. She's a family court judge in DuPage County. And my wife practices law out here. And so she's a family attorney, soon to be assistant state's attorney in Kane County here as well, doing the juvenile court. So we've been in and out of involvement with CASA for almost as long as I've been doing this work. So history with addictions through all this. Even when I was a probation officer, I was always a drug counselor. I've been a state certified drug counselor for 15 years now. And in doing this type of work in opening Lighthouse, we didn't really have the places that we wanted to send people to as probation officers. There were a lot of facilities that were closing down, a lot of facilities that were treating individuals only because they had premium insurance, and also then following the guidelines of those insurance companies in terms of when somebody gets better or not. So when we opened Lighthouse 5 years ago, we made it our mission to work with anybody that comes through the door, regardless of their ability to pay. And then we also made it a very, very purposeful, intentional statement when we were doing this to not follow direction of insurance companies in terms of how long somebody needs to be treated. And so what we do is we do work based on clinical need, not some suit in Bloomington that thinks somebody is fixed. And so what we're trying to do is actually bring the right amount of treatment to individuals in the most needed population. And one more thing, about 2 years ago, we started working with the Kane County Sheriff's Department. When Sheriff Hain got elected, he came to us and asked if we would design and implement a program to work with the addicted population in the jail. So for the last 2 years, Dr. Holtzford and I have been working with that population. Dr. Holtzford provides all the medication-assisted treatment for individuals with opioid use disorder in the Kane County Jail. And at this point in time, I have an entire cell block in the jail. It's called Recovery Pod. We've got about 60 men and around 20 women that are involved in our program in there right now, and they're all dealing with substance use disorder, crimes relating to drug offenses, things like that. And we're doing a ton of work in there, and that's actually my focus right now, and that's going to be the focus of my part of the presentation today, is talking about the most needed population and what we're doing to serve them right now.
Amazing. Thank you both. What a great introduction. And it's great to get to know both of you. I believe that Dr. Steve will be going first. If you'd like to share your screen, and while you're doing that, just wanted to let everybody know that both of our presenters have agreed to take questions throughout. Please use the chat function, use your emoji, that the signs to raise your hand, unmute your microphone and ask the question, but we'd really love to capture those real time, as well as saving a little bit of time at the end to answer questions. So you'll be able to do it either way. And there may be times where Sandy and I ask our presenters to stop for a minute because they've made a particular point that we all think is important to drive home. And so we want this to be interactive. We're so glad that you're here. And Steve, I'm going to turn it over to you.
Can you guys see my screen?
No.
Oh, no. Okay.
Well, is it just me? I can't, but I know I've got it too, and I think I can. Give me 1 second here.
Okay.
It's not fun if it all works exactly like it's supposed to. Oh, we can see. I mean, that would be really boring.
Good thing we had those 2 test sessions.
We can actually see it now.
Okay.
Sometimes, can I tell you something? Sometimes it does take a minute. There's a lag. It's not so I can hear and see everything you're saying in real time, but don't be surprised if there's a lag with the PowerPoint just a little bit.
Okay. So now everybody can see my screen?
Yes.
Okay. All right. So I cannot see the chat now. So feel free to interrupt me if there's anything in the chat that's interesting, any questions. I'll just sort of dive in. I've sort of done this in my bedroom a couple times, and one time it was like 20-ish minutes. The next time it was 36 minutes. So I have no idea what's going to happen. You guys have no, so feel free to stop me.
We will.
We're very pro at doing this.
Yeah.
We're ready for the 20-minute to 36-minute presentation.
That's right. All right. So I always like to start these presentations with sort of what got me into addiction medicine. I mean, besides being immersed in the opioid crisis in the emergency department with overdoses, and I was there during all the early 2000s and into even 2021. it's just been a catastrophe in the emergency department. But even that really didn't, I was just sort of like a cog in the wheel, just like, oh my, I can't believe another one, another overdose. This is getting worse. This is getting worse. Where do we send them? It really wasn't until I read these two books that I sort of a light bulb went off that I was probably in a position to actually do something about it. So these are books that I would strongly encourage everyone to read if you have any interest in this topic. The first book is Dreamland. These are both 2015 New York Times bestsellers. You may have even heard of them. Sam Quinones is a LA Times reporter, wrote Dreamland, which really explores how we got into this mess. It takes on, it starts in a industrial town in the Ohio River Valley that was basically carved out when all of the jobs went to China in the 70s and early 80s, and nothing was left, no good jobs. It takes you into the Mexican drug cartels selling black tar heroin and how efficiently they were able to manufacture it, market it, distribute it all over America, purposely avoiding large cities where there was already gang activity that sort of controlled the drug trade. So really a mass expansion of heroin in very purposely very at-risk communities. Just really a phenomenal book. Chasing the Scream, again, also 2015, written by Johann Hari, who is a British journalist. This is a book that chronicles what is really the 100-year failed war on drugs. Trying to combat drug use and drug addiction through a criminal justice lens does not work. It does not have to be studied anymore. We know it doesn't work. It's been 100 years. You guys have probably seen I think it's HBO or Netflix, the U.S. versus Billie Holiday movie. This book sort of touches on that, on the DEA's following Billie Holiday around because this black woman had opioid use disorder and was singing songs that were threatening to the state. I mean, it's just, again, both of these books, once you start them, you can't stop them. And then so I really, this is sort of what got me started in substance use treatment. And as Nate kind of said, I'm sort of more of a opioid use disorder treatment is sort of my niche. And so I started to treat patients with opioid use disorder. That's heroin addiction, pill addiction. And the patients got better. They got better. And it wasn't even that hard. It didn't even take that long. And it sort of dawned on me, this is work that needs to be done. Nobody's doing this work. Why is nobody doing this work? Why are these people, dying for care and they can't get it? And this is out in the western suburbs. You can imagine how tough it is to get it in other areas of the community. So that led to me slowing down in the ER, taking the addiction board, studying addiction, and then linking up with Nate, and the rest is history. So these two books, it's fun when a book changes your life, but these are two books that really changed my life. So if you would,
Dave,
yeah.
This is Meha. I'm going to save my question until the end, but I do want to go back to what you said, whenever it's appropriate about we've been fighting 100-year war, and the way that we've been fighting it has been unsuccessful, does not need to be researched anymore. And I wonder how much of part of that losing battle is changing the mindset of, what people are willing to accept on top of changing the strategy. And so if you can address that now, or you can address that later, but I know for me, I have my own perspective, but it, is part of losing that battle, not, as part of losing that battle, not having everyone on the same page.
Yes, yeah, and it is people seeing substance use disorder as a fault, as a
Moral failing,
a defect, a moral failing, rather than a medical condition or brain condition, complicated as it may be, but it's not a moral failure. The substance use disorder is a public health issue with complex interwoven factors, biopsychosocial, we'll get into that, and so sort of, but it is not a moral failure, and as such should not be treated as a criminal justice issue. These patients, should be treated for the underlying disorder that they have, rather than jailed. And that, so it's stigma around patients with substance use disorder. It's, mental health and substance use disorder are stigmatized by, the most of the population, and I'm speaking from experience, the medical community, tragically. Now Nate and I do see a shift. We really do seem to be at an inflection point. It's going very slowly, but books like the two books I just mentioned, that was 2015. That's 6 years ago. So, but slowly but surely, I think Nate would agree with me that we're starting to see things sort of bend, and the fact that we're in the jails and we have a sheriff that understands this. It's just the momentum has to sort of be built, and I think we are actually getting somewhere finally. So here's the definition of addiction. This is the definition by the American Society of Addiction Medicine. So addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Furthermore, prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. And it's very important, because really it is like diabetes. It is like hypertension and heart disease, in the sense that you treat it. A lot of people do very well. A lot of people, their diabetes gets under control. You don't need much medicine. They don't need much motivation. Those patients are easy. Addiction is the same way. There are patients that get treatment for their substance use disorder, and they get it. They're off and running. But keep in mind that the substance use disorder is a relapsing condition. So the fact that patients start drinking again or start using heroin again, it's not to be interpreted as a failure. It's a natural part of the condition, and people just sort of have to look at it that way. So here at a brain, I'd like to spend a little bit of time. So what is actually happening in the brain? And this is specifically opioid use disorder. It's a little bit, all of the drugs of abuse sort of have a common final pathway, which is secretion of dopamine. But this is specifically opioid use disorder. So there are areas in our midbrain that basically that have the sort of the nickname, the reward center. So when we do things that are good, say we get an A on a test, we get a raise at work, we hit the game-winning shot, our brain, our midbrain, releases a little bit of dopamine in response to that event, and then that dopamine causes our prefrontal cortex to feel good. We feel good about ourselves, and therefore you can think about it evolutionarily that is helps us evolve because we're more likely to do that behavior. Hey, that felt good. I'm going to continue to have my job. Hey, that felt good when I hugged my kid. I'm going to continue. So you can think about how that makes sense. It's those areas of the brain are very primitive. It's not a part of the higher levels of the brain. It is sort of the reptilian brain, I'll say. You can't really control that center per se. It's just dopamine gets secreted, and we feel good about what is happening. And those areas are the nucleus accumbens and ventral tegmental area are the big areas that are part of that. And then the amygdala we'll talk about shortly. So it's, I think the important point is that the opioids are acting at a very primitive area of the brain where we don't really have conscious control over. So here's how that sort of looks like with opioid use disorder, how the disease of opioid use disorder can manifest. So the black line, think of the black line sort of as dopamine levels. So those of us going through life, we're sort of in the normal range. We get a little bump of dopamine, when we do those good things, but we generally are not in the euphoria range. But with opioids, it is sort of an unnatural, it's not an endogenous endorphin, it's an exogenous opioid, lands on that receptor, causes a huge spike in dopamine, and that gives us euphoria. And so, people with that are prone to addiction, and we'll talk more about that, really can be, affected by that. Like this is how I'm supposed to feel, despite these horrible conditions that I'm in. I'm getting abused, or I have no educational opportunities, no financial opportunities, but yet here's something that makes me feel this good. So, and then the black line goes back down when they're not using, and they use again, and you can see that for a while they still can use and feel really good. But unfortunately, what happens is that the brain sort of compensates. The brain likes homeostasis. So it's not going to continue to just dump all this dopamine in our reward system. It's going to back off on that mechanism. So it decreases the number of receptors. The receptors become less responsive to the opioid. And then at some point here, you're using more, but getting less euphoria. And then when you don't use, the dopamine is drastically cut, and then you get withdrawal symptoms. So that's sort of, and we need dopamine to get through our day. We need it to get out of bed. We need it to go to work, to get dressed. If we don't have dopamine, you can think about dopamine as kind of motivation. If you don't have any dopamine, nothing's going to get done. So these patients, they get trapped. So they've developed this tolerance where the cells don't secrete dopamine unless there's an exogenous opioid. And then if there's not an exogenous opioid, they get horrible withdrawal symptoms. So then
Steve,
yes.
I'm so sorry. If I'm understanding you correctly, you said two things that seem really important to hang on. One is the more you use, the less of an effect it has.
Yes.
Okay, so then you end up using more and feeling less.
Exactly.
In addition to that, the dopamine that you're talking about that gives us motivation entirely goes away. So it's not created by anything else. So getting that A on that test, eating a really good donut, whatever it is that, whatever you're.
Exactly. And unfortunately, it's not, the dopamine is, we've all seen those tragic stories of the parents leaving their kids to go use because they don't get dopamine from hugging their kids anymore. It's just, again, it's not a cerebral cortex issue. It's a midbrain issue. And basically they're just driven to get that little bit of dopamine to just sort of to get through the day. And you see, so that they're developing tolerance. So you have to get more exogenous opioid. So now, instead of taking 5 Norco, they have to snort heroin. And now the economics of it, it's cheaper to inject heroin and I can get more dopamine release from injecting heroin. So now all of a sudden they're going from pills, and in a matter of months, now they're injecting heroin. And at that time, there's with that trajectory, it's more money. So they're engaging in risky behavior, health-wise, and that is sort of the snowball effect of opioid use disorder. So now you've got a situation here where these patients are not getting any euphoria. Again, it's just exogenous opioid just to feel normal and get through the day, and that's what we see all the time.
That was a great explanation. We do have another question in the chat. Does medication for mental illness work the same way as opioids?
No. Depending on what medication it is, I will talk a little bit about buprenorphine and methadone. Those are medications that are used to treat opioid use disorder specifically. But no, most of the depending on what it is, it's a serotonin reuptake inhibitor, or for instance, Paxil and Lexapro and selective serotonin blockers. But none of the normal sort of anti-anxiety, antidepressive medications, bipolar medications work on this receptor.
Thank you.
Steve, I've got a question.
Yes.
What I want to know is, I'm thinking this might be how meth works too, because on Dr. Oz, they had Tom Arnold's sister, who's known as the Queen of Meth. It was just yesterday. It was interesting listening to her. Her mom had given her a half of a pill when she was little so that she could lose weight. I mean, that was what that pill was meant for. And she said it made her feel really good, kind of like what you're talking about. And it, one thing led to the next. So do you think it is kind of like this whole meth thing also?
So it's just a different receptor. So meth doesn't work on the mu receptor, which is where the opioids work. But yes, the final common pathway, again, just like alcohol and cocaine and meth, it's all about getting reward. Some medications or some drugs of abuse just take a different route to get that reward. But yes, meth, it's the same thing with meth. And I would just, so I was just going to make a comment about Dr. Oz, but I don't think I will. So he's still around, huh?
Oh, yeah. It has a different slant, I think, to his show. I haven't watched it regularly, but
hopefully one that involves truth. I don't know.
Yeah, I don't know how true it all is, but that was an interesting interview yesterday.
Okay. All right. So I like this slide. It's sort of kind of related to some of it, but this is from PCSS, an organization that I've involved with. So motivation, again, it's sort of a combination of getting positive reinforcement and avoiding negative reinforcement, and this is also important. So we talked about dopamine in the nucleus accumbens, and then again, if you're susceptible to and that's of course complicated, then you may be triggered to use again and again and again to seek out and do more. And the other factor that is underappreciated is that these patients with opioid use disorder or on their way to opioid use disorder. We can talk about the diagnosis specifically if you like, but so much of it is not necessarily seeking positive reinforcement, but it's trying to avoid negative reinforcement. The limbic system of the brain, again, primitive area, you have no control over your limbic system, and a big part of that limbic system is the amygdala. So when the amygdala is firing, it gives you anxiety, fear, distress. It's just sort of the worst type of anxiety. And in patients with opioid use disorder, this area gets magnified. So the opioids serve two purposes, really. They give you dopamine and they calm down the amygdala. And patients in opioid withdrawal, which we see in the ER all the time, they're incredibly anxious. They're just the fear and the anxiety and that the avoidance of that negative reinforcement dominates their lives and their day. I mean, there is part of the motivation is, I need to score because I need to go to work, but so much of it is I need to score because I don't want to get sick. I don't want to get sick. It's this horrible dysphoria that is the emotional component to opioid withdrawal. So both of these are very key factors. So who gets substance use disorders? And like in most things in medicine, it's a combination. It's a combination of genetics and environment, and it's probably different in every person. That's what I've been coming to learn. Really, everybody's different as it relates to substance use disorder. But your genetics give rise to opioid receptors, how receptive and sensitive they are, dopamine, novelty seeking, harm avoidance, impulsivity. Of course, mental health disorders are also, there's a genetic component. And of course, obviously the environment is important. Where you live, who your parents are, your siblings, friends, adverse childhood experiences or ACEs. There's an ACE score, which is 10 factors. Were you ever unstably housed? Were your parents divorced? Were you ever hit? Were you anybody in your household addicted to drugs? Anybody in your household go to jail? These types of things. There are 10 of them on the survey. We find a clear connection between a higher ACE score and vulnerability to substance use disorders. Of course, it makes sense. Psychiatric disorders, lack of positive experiences, and of course, illicit sources. A big part of who develops substance use disorders is who has access to drugs. And if there are drugs in your house, in your friend group, in your school, then that's certainly a large risk factor to develop substance use disorder. And what we're just starting to understand is the large factor of trauma. Trauma affects, and volunteers at CASA, of course, know trauma in our lives has long-lasting effects, and one of those is absolutely the development of substance use disorder. We've got a history of trauma, and traumatic stress leads to strong emotions and physical reactions, which increases your risk of substance use and other suicidality. and then that substance use puts you at higher risk for more trauma. You can see how it just sort of can be a cascading situation. And I just threw in this exciting development of epigenetics. There's been a lot of work on, not just the genes that you got from your mother and father, but the interaction of our lived experience on those genes. It doesn't necessarily change the DNA itself, but what we are learning is that trauma and life experiences can change the expression of genes, make genes more active versus less active, the expression of certain proteins that might be related to development of substance use disorder. So just very, I said we were kind of at a tipping point, and one of the things that that I'm excited about is the understanding of how genes might work in patients that develop substance use disorder. Just really exciting stuff. So let me just touch on what I do, the medical treatment of opioid use disorder. There are 3 medications that are used to treat opioid use disorder. So with opioid use disorder, again, I'm talking about pills such as Vicodin, Percocet, OxyContin, using heroin, fentanyl, those types of drugs. So methadone is one possibility. It's been around for 50 years. Effective. The problem with methadone is you have to go to the clinic, most days. It's oftentimes those clinics are not exactly accessible, so there are transportation issues. But methadone does work for the right patient with opioid use disorder. Vivitrol is actually an injection of naltrexone. Naltrexone is a blocker on that receptor, on that mu receptor. And that blocker seems to decrease the cravings for opioids. And buprenorphine is the one that in most people's opinion is the best one for the most number of patients, because buprenorphine is what we call a partial agonist. So it does go to that same receptor, but it doesn't cause a spike in dopamine. It causes like a nice, slow and steady rise in dopamine. So it helps people's withdrawal symptoms and cravings. And again, these are people that stopped getting high a long time ago, but they just use to feel decent and go to work. And buprenorphine allows them to do that. It's got a long half-life. So instead of injecting or snorting heroin 10 times a day, they're letting a pill dissolve under their tongue 1, 2, or at most 3 times a day. And that coupled with counseling and therapy is really how opioid use disorder should be treated in 2021. Alcohol use disorder, it also has medications that are helpful. I think these are underutilized. I think everybody that has alcohol use disorder should at least be tried on these medications that the evidence is not quite as robust in terms of when compared to opioid use disorder, but it's still pretty darn good. So again, naltrexone goes to that same receptor. So it's interesting that receptor, it's not as if alcohol is an opioid and goes to the mu receptor. So the fact that this works for alcohol use disorder means that receptor has something to do with the whole craving mechanism that we have. There's naltrexone in some diet pills as well. So if you block that receptor, people tend to drink less alcohol. They're less likely to pick up drink number 1, and if they pick up drink number 1, they're more likely to have 2 and not 6, 8, or 10. So it's a good medication. Acamprosate is another medication. This actually, we're not exactly sure how it works. It probably works on a different receptor, but this also would decrease its cravings. The only problem here is it is 3 times a day, and it's hard for people to take something 3 times a day. and disulfiram or antabuse, is a medication that works on the negative reinforcement philosophy, where you take this pill in the morning, and if you drink alcohol, you get sick. So it's it's for those for an isolated patient. This does work well for, but it's got to be a very motivated patient, generally with an incredibly supportive home environment and supportive spouse, and to ensure compliance. And then stimulant disorder, such as meth, cocaine, they are working on some medications for that. There's nothing FDA approved. It's an active area of research, as you might imagine. All of these things are, as we find ourselves in the middle of a substance use disorder epidemic.
Hi, we
Dr.
have a
Holzford?
question.
Oh, I'm so sorry. Go right ahead, Mom.
Sandy?
I was just going to say that we have a volunteer that has their hand raised, so they have a question.
Sure.
And
Sorry.
her name is also
That's-
Sandy.
It's me. This is Sandy. I'm getting extremely discouraged as I'm listening to this. My child in CASA is a 14-year-old girl who has all the things against her. Her genes, the trauma she's been through, not only with drug use at home, but sexual abuse. And she's not addicted to drugs at this time, but she's a perfect candidate. She's in a treatment, or she's in a residential, and she's getting counseling, and she's getting chemical abuse, education. But her ACE score, if I remember right, I don't remember all the 10 things. She's got them all.
Yeah. Yeah.
So it's really, really discouraging.
Poor thing.
Yeah.
Yeah. Well,
adolescents are notoriously tough to work with in this population as well, because most of the research that you're going to read, not to put another cloud on top of a cloud, says that it takes somewhere between 8, 9, 10 times sometimes for a adolescent to really pass through a treatment program to achieve some type of sustainable sobriety or recovery. A lot of the stuff that we do with adults works on value systems and things that kids necessarily don't have developed at that point in time, and so it's a hard road, and there's also not a lot of great treatment options for adolescents. So I'm happy to hear that you found a place for her to go, because I struggle with that routinely.
Okay, thank you.
So I think we'll take a few questions for Steve, and then we'll take a 5-minute break and come back and hear Nathan's presentation. If you don't mind, I'd love to hear just a little bit more about that connection. You had a slide up, Steve, that talked about trauma and the relationship that it has to substance use disorder. How is it a correlation? Is it connected? Does one cause the other? Is it just found that people who experience substance use disorder have often had those adverse childhood experiences? Do you mind talking a little bit more about that?
yeah. So I think, and Nate, feel free to chime in, but I think that we are only starting to understand the effect of childhood trauma. I don't think it's been studied enough. We probably should have been studying it for the last 50 years, and we're not. And there are plenty of people that have horrible traumatic childhoods and don't develop substance use disorder. So what's happening there? We just don't know. But clearly, a history of trauma decreases your ability to feel reward. It's very difficult to be abused at home and then go to 5th grade and sit in there and learn your fractions and get an A on your test and then come back. So So when that fifth grader is a freshman and gets given a pill that, artificially increases her dopamine, she thinks to herself, so this is how I'm supposed to feel. It's because trauma has affected her ability to get that reward that she should get from learning fractions.
Yeah. So Maha, we actually have the ACEs in our biopsychosocial that we do with everybody that comes into to treatment here, because what they are finding through that study is almost everybody that has some type of severe addiction issue has trauma. And so, like Steve said, that there are plenty of people that are traumatized that have these experiences as kids that have developed resiliency in some capacity somehow. The people that we deal with are routinely above a 4 or 5 on an ACEs.
Routinely.
Routinely. I mean, I would say more often than not. We're seeing multiple hits on an ACEs scale. And then in addition, what we're not taking into consideration, so the ACEs is pretty limited as well. But when we're not taking into consideration the population that I'm working with now, incarcerated and homeless populations, we're not taking into consideration these chronic traumas that people continuously experience as a result of addiction. And so this circle just goes over and over and over again. And that, while trauma is perception, it's not just the abuse event, it's the interpretation of that over years and things like that. When you're something like homeless or incarcerated off and on, or even in prison, and I'll talk about that in my presentation as well, what that does to our fight or flight response. When we're dealing with these individuals, they are continuously traumatized. So one of the things that we're doing right now in the Kane County Jail is we have a trauma therapist that works with our population. And almost everybody needs her help, and she is one person, and it's absolutely needed. There's absolutely a connection. We're just trying to figure out exactly what the best road is to combine all of our efforts.
Thank you.
And the other, quickly, I'm just beginning to learn about generational trauma.
Yep.
So, and it makes perfect sense, but our long history of racism in this country, that we have not dealt with. But even the say someone has been subject to racism, but they go to college, they're a lawyer, and then their kids are raised in Geneva. So, but the racism that the parents and grandparents experienced is affecting that kid that was born in Geneva, unmistakably. So while the kid is born in Geneva and is going to go to U of I, his DNA is not the same as the other person's DNA because of historical trauma. And those are things that we're just now beginning to kind of understand.
It's a great point. Do we have any other questions for the first part of this presentation? I think we've asked several of them throughout. Before we go on break, I think it's really important. I've seen it in your presentation. I've heard both of you use the term. Can you just explain a little bit more how we've gone from talking about substance abuse to substance use disorder? It seems like one of those things that we hear interchangeably, but I remember we did have a presentation, or I heard it somewhere. And so it's just good to kind of get a little bit of background information. Are those terms interchangeable? Is one better than the other? Do they mean different things?
Yeah, the preferred term, again, we're trying to get away from stigmatizing language. So, person with opioid use disorder rather than opioid addict, opioid abuser. So trying to make less stigmatizing, more clinically accurate language.
And that helps the individual, but also that's coming from the DSM, the Diagnostic Statistical Manual, where we no longer look at abuse and dependence. We're looking at the disorder itself, and so with different degrees of severity of the disorder. So it's not just the latest, we're going to call this thing this now, which happens a lot. I mean, so Steve provides medication assisted treatment, but now it's, I mean, what is it now, Steve? It's MER, or not even, there's not even a T in it anymore. I don't even know what we're doing with that, but
Yeah.
right. So, but like,
So the thought was medically assisted treatment, but wait a minute, medicine is actually the treatment. It's not assisting. So we don't say insulin is diabetes assisted treatment. So so the new terminology for prescribing buprenorphine and methadone is either medication for addiction treatment, and so it can stay with MAT, or MAR, medication for addiction recovery, something like that. So there's lots of language changing, but all of it is going in the right direction.
Makes sense. Thank you. So why don't we take just a very quick break and come back right before 11:30, say 11:28 thereabouts, and we'll start right back then. If you want to turn your camera off or turn your volume off, we'll see you guys in just a few minutes. All right, we're going to go ahead and get started here in just a quick minute. James, I see that you have your hand up and we have both of our presenters back. So if you have a question, we'd love to hear it.
Actually, I had to step away for a couple of minutes to take a phone call. And when I came back, the meeting seemed to have stopped and I didn't know why. So that's why I raised my hand.
I'm so sorry. That's like
No,
not
that's
a great
okay.
surprise. You're like, wait a
That's
second, I
all.
see there's 40 people in this meeting and they're all being
Yeah.
really quiet.
Yes, they were. And all I saw
We
was
did
your
it
initials.
intentionally.
Well, I know. I heard you say that at the beginning of the meeting. So I apologize for interrupting.
No,
I was very happy
not
to
at
see
all.
your face suddenly.
Well, welcome back, everybody. We're excited to have Nathan present as well. This has been awesome. I think when we were first talking about this, both Steve and Nathan were talking about how they could really easily fill up an hour and a half, and it's just been packed and great. So I'm going to go ahead and turn it over to you, Nathan, if you'd like to share your screen.
Sure, absolutely. I'm actually going to start with just telling a story real quick.
Please.
But first of all, thank you again for having us here. And for anybody that didn't hear us right off the bat, my name's Nate Landrum, the clinical director at Lighthouse Recovery in St. Charles. And Dr. Holtzford and I work together both at Lighthouse. He's our medical director, and Dr. Holtzford is also working with us in the capacity as we're running all the treatment services in the Kane County Jail right now. So what I'm going to be focusing on with my side of this today is actually talking to you about the jail programming. Everybody here as a CASA volunteer is involved in the legal system in one capacity or another, or has been. So I decided to kind of focus on what we're doing in the system, as well as why the treatment that we're doing seems to be working. So I want to start with a story, though, and Maha, you can moderate this too after I get done, because I'd actually like to hear input from people that are volunteers about what they think about what I'm about to say. This is something that's occurred in our agency in the last 2 days with somebody that we've been working with for almost a year and a half, both working with Dr. Holtzford and I, not only in the jail programming, but in the release programming, medication-assisted treatment, working this woman through a pregnancy in the last 9 months while on medication while she's been dealing with opioid use disorder, as well as a variety of other substance use disorders. So the reason I'm bringing this up in the capacity of CASA here is there's also a 2-month baby involved in this. And so I want to see what the general consensus is, or even just individual opinions about what people think about this. So about 3 days ago, we received a phone call from a woman that we've been working with, like I said, for about a year and a half. And she had given birth to a baby about 2 months ago. And through her entire pregnancy, she was sober. And Dr. Holtzford worked with her with medication-assisted treatment and keeping her off of all the drugs, working with her physicians, even through the course of childbirth. When somebody is on our medication and giving birth to a baby, sometimes we have to get involved with DCFS right off the bat to make sure that they're aware that those medications are prescribed by us and everything's above board. So we've been working pretty closely with this woman. I met her first in the jail program. She was in our women's pod almost 2 years ago, about a year and a half ago, with severe substance use disorder and all the criminal elements that come along with that sometimes. So a couple of weeks ago, this woman has returned to active crack cocaine use, and she lives in the area. Obviously, I'm not going to say names or even towns at this moment, just in case this happens to come across anybody's desk. But just to kind of give you a background of what's going on here, she returned to crack cocaine use. And then 2 nights ago, disappeared from her home with her 2-month-old baby. She was not being communicative with us. She was not being very forthcoming about her whereabouts. I knew she had the child with her. That was our primary concern this entire time, is trying to find that baby. We got Aurora police involved. They got patrol involved. We had heard rumors that she was with this person or that person. This woman that we've worked with is also and has been a prostitute in the past, and so we had different connections in places that we were looking. And in communication with her, the baby appeared to be safe, despite the fact that this woman was in an active relapse, and despite the fact that at a certain point she ended up in a location with a group of women that were prostitutes. And we were working really hard trying to find this kid. So all through the night, having the police department knock on doors, having us in constant communication. When you're in a crack cocaine relapse, you're not really awake a lot during the day, but at 2 a.m., that's when you start calling people. And so she's calling us at 2, 3, 4, trying to get her out of there, trying to get her back home. If the police would have found her, which they were looking, and we had all the addresses lined up, they would have absolutely taken this baby, and rightfully so at this point in time. But what we ended up being able to do was get the mother and child home to her mother's house, so the child's grandmother's house, safely. That was about 7 a.m. yesterday morning. The baby's safe, is taken care of. And we're working today and yesterday to try to get this woman into treatment up at Gateway Lake Villa. So through Dr. Holtzford, we got her a bed. She's got the option to go. We're going to get her an Uber today to go up there. So by all accounts, a happy ending, if there is a happy ending to be had here, with a variety of near misses along the way. And so my reason for telling this group that story is I am assuming, and correct me if I'm wrong, but I'm assuming that everybody's head snaps immediately to, where is that baby? How is that baby? What's going to happen with that child next? And as that's your role in the court system. But I'm kind of curious as to, and this isn't laden with anything and no judgment attached to anybody that responds to this, but I'm curious as to how this group thinks of that mother in this process, and thinks of what was the next thought that comes into somebody's head when we're dealing with a completely helpless infant who has no control, obviously, of where she is, but then also dealing with a mother that is absolutely dealing with substance use disorder, in some respects doing the best she can, but also bringing this child to a crack house, bringing this child to a home with prostitution involved in it, in and out. And so I kind of wanted to open that up and see if anybody has just a vague opinion about what they would think or what they would, I guess, do with this parent in the next steps moving forward.
We've got a hand up. Casey?
Please.
I guess my couple thoughts right off the bat is that obviously not the best place for the child, but because it's with a group of prostitutes, to me doesn't mean that baby hasn't been watched over by some of the women who are prostitutes. They can be loving, caring people, I think. The other thing that hit me was if we can get the woman to a place of care and treatment, the biggest thought in my mind is what steps can be put in place, if any, to ensure, or as much as possible, that when she comes home, there are things put into place to help prevent an escape with that child again.
Yeah. Thank you. I really appreciate that viewpoint, and for sure, and all those things are actively being taken into consideration already. And that's actually a great response, and that's kind of what I'm looking to see where people's heads are with this type of situation.
We have another hand up. Barb?
I have a question. You mentioned, I think that's a kind of a unique, maybe it's not a unique situation. How often do you see parents with children and that the children are okay, like this baby was okay? But I'm just curious, how often are you seeing that? Because it sounds like the purpose is to try to keep the parent with the child, or keep the child with the parent as long as the child is okay.
Yeah, we see this regularly, and the bulk of our clients are parents, and especially in the jail system, we're dealing with individuals that are in and out of their home lives with their children. So this particular situation, I mean, I can't say that this happens all the time, but it was one of those things where this is occurring and we know how to handle it because this is something that occurs regularly. So, so in terms of just the child being okay, you know, and that's kind of I guess that's an opinion. And when I say okay, I mean safe. You know, if this was a little bit of an older child, there's a whole other thing, you know, a whole other mess involved in this, and what the child saw and how that child was cared for and those kinds of things. So, but this is kind of a common occurrence with our population, unfortunately.
Anyone else have a take on Nathan's question?
Really, just
does anyone want to share an opinion?
Yeah.
I think it elicited a response from all of us. I do. I believe that. I'm curious. Yeah. Okay. There we go. Perla. Oh, there we go. Perla and then Gail.
Can you guys hear me?
We can't.
Okay. Yeah, I guess I was, thinking about this. I don't know. I feel bad for her, I definitely can see how, when you're dealing with addiction and whatnot, like you're pretty much lost, right? And so at that point, your body is just kind of craving whatever it is that it needs, to kind of fulfill that need. And in this case, I've been learning that, even though, yes, it's not the right type of situation to bring in a child, it's not safe, etc. I mean, I think from her perspective, she doesn't know that. Like, she just knows that that's like her safety, and she's bringing the child wherever she's going. And maybe that's just her way of being the best mother, that she can be. So, while it's hard to understand from our perspective, because we kind of have, we're of a sober mind, and we know that, certain things are good or not, she doesn't see that. So who knows if maybe somehow, she grew up with also that kind of similar traumatic experience. And so therefore she's just kind of mirroring that. Yeah. So that's just kind of, my kind of comment on that, where I feel a little bit more compassion for her. I'm glad that, the baby's okay, and hopefully she gets the help that she needs.
Okay, thank you. And there was one more person, and that's perfect. And I want to come back to the couple words you said in that. I think there was one more, Maha, right? That raised their hand.
Absolutely. Gail? Gail, your microphone's muted.
Sorry.
No, you're good.
This gets back to my thought earlier about the generational genetics that takes place and breaking that cycle. So many of my cases have involved grandma, mom, granddaughter, all having children young, all not knowing, as Perla said, all feeling like they are doing the best they can. What else can we do to help break the cycle?
Okay,
That's all.
That's amazing, and that's perfect. So of the people that spoke up, I wasn't expecting anybody to take the opposing stance in this group of individuals and lock this woman up, and and she's no good for her kid, and that's why it's truly important for you all to be doing the work that you're doing, is because what I really was expecting by asking that question was compassion, which was given. And compassion for the individual, I mean, obviously for this child who has no control, but compassion for this mother who has been abused, who has experienced generational trauma like Doc was talking about, who has experienced all these things in her life that inform her decisions up until this point. And she was terrified the entire time this was going on. And when you're in a constant fight or flight response, like she has been her entire life, all that's reactivated again through this relapse. And she's not listening to reason. She's not thinking clearly, but she does have that instinct to take care of that child. And the baby was safe. And the baby is okay this morning. And the police have checked in on this. And so the police are still involved. And now DCFS is obviously involved. And we're working all these things out. But what we do at Lighthouse, and what we're doing in the jail right now, which is why it's so amazing to find somebody like Steve and the people that we have working here, is that we see all of these individuals as human beings. We see every single one of these individuals as people that are experiencing this. And that's why when Steve was talking about stigmatizing language, to call someone an addict or a junkie, and even doctors, and Steve said sometimes doctors are the worst at this sometimes, as they see the same repeat people in the ERs and the EDs over and over again. To use that language and to alienate this entire population is wrong. And so as we do these speeches and as we bring these ideas to people, I mean, obviously I'm preaching to the choir here with the group that I'm talking to, but even then, our compassion for that child sometimes overwhelms our compassion for that mother. And truly what's going to happen, and DCFS is probably going to make this happen as well, because they'll usually err to the side of this, but that baby will be back to that mother. And we have to work as a whole, as a systems approach, to find out how to deal with that woman, to how to help her family, help the entire unit, the entire system, so that this type of thing doesn't happen again, or we're mitigating the risk of it happening again. So I appreciate you kind of indulging me in that little story, but this is fresh. I'm actually working this right now, and we're getting this woman into treatment this morning as we speak. And so this was just something that that we deal with on a regular basis, as will you. And so with the time that I have here, I do want to talk about the programming that we're working in the jail and what we're doing with individuals that are essentially the least among us and the people that are the most vulnerable based on what Doc was talking about, the generational trauma, the things that have occurred in their backgrounds, the trauma just within them from their experiences growing up, those kinds of things. So I am going to figure out how to share my screen. I'm pretty good at it. I did it this morning. And boy, here we go. I think I did it. Maybe.
Yes, we can see it.
Hey, wonderful. That's me. That's also the sheriff. If you guys know the sheriff,
We do.
if he's a great guy, he will put his picture on every single thing that he could possibly do. I couldn't remove it. I couldn't get it off of the screen this morning. I wanted to make my picture bigger, but his is permanently locked into this PowerPoint. He's done that on purpose. This is the speech that we actually have given multiple times over the course of the last couple of years since we started this program. So Sheriff Hain came into office 2 years ago. And when he did come into office, he came to us almost the week before and said, look, if I get elected, will you come do this with us? And the day after he got elected, he called us. And the reason why we're doing this work is illustrated in this first chart. And the reason why we're working with individuals that are in the system is because starting around the 70s or 80s, we just started arresting everybody if they were dealing with substance use disorder. And a lot of this had to do with what we are now kind of opening our eyes and accepting based in racist drug policies that have been occurring for the last 100 years. But crack cocaine laws, marijuana laws, heroin laws have all been based in racist law and racist policy. And that might be just an opinion coming from me, but I think that a lot of people, when they look into this, would agree that this is kind of the direction that we've gone. And if you look at this, and these are stats that we've gathered, and we tried to get the most kind of objective information that we could. So this is coming from the Sentencing Project, but also the same numbers coming from that liberal think tank, the FBI. We're getting all the numbers from that. So hopefully people can see this and realize this as objective data. But we're looking at this in the early 80s when we started locking people up for crack use in the inner cities. This is what we did to our prison population starting in the early 80s. It went through the roof. What we did with this is we started locking up Black and brown fathers. And when we started locking up Black and brown fathers, we left kids in communities without role models, without male figures in their lives. The housing projects in Chicago started dealing with this in an extreme fashion, where the children started outnumbering the adults because we had locked up so many of the Black and brown men that were there based on drug policy and drug law. So what we saw and what we've seen for a long time is this is the population we have to work with. They keep getting arrested. Once you're in the system, you can't get out of the system very easily, especially when there's no help. There are no treatment programs in most jails and prisons. It's just not something that people do. So what ends up happening, though, is these individuals come through our prison and our jail systems, and then they're released back into the community. And as you see through this chart, just pretty simple, the opioid deaths in this county have been kind of on a rise. 2016, 17, and 18, we were around 190, in 2018, and so it's been pretty prevalent. And the reason people are paying attention to this, and people are talking about this in Kane County and DuPage County and McHenry and all these places out here, and the reason now we're having an opioid crisis, and again, this might just be an opinion, so take this for what it's worth, but it's because people who look like me are dying. We have had this issue in the inner cities for decades, but now all of a sudden, because someone in Naperville High School overdoses on heroin, we have the DEA that come and hold town hall meetings out in Naperville and Geneva and St. Charles. We have an opioid epidemic now because white people are dying. And we have an opioid epidemic that has been occurring under the radar for a variety of years in the inner cities. But this, for Kane County in particular, we were coming into a pretty bad couple of years. And so what ends up happening is if you are incarcerated in any capacity, and if you are untreated, you are 74 times more likely to die of a fatal overdose when you are released. And it's got a lot to do with your tolerance. Your tolerance is lower than what it was men. A lot of people return to the same amount of use that they did before they got locked up. But right now, especially through COVID, and Steve alluded to this a little bit, the economics of the drug trade are all screwed up right now. So when you're using heroin before you get locked up 2 years ago, you have no idea that the heroin you're now going to purchase when you leave contains fentanyl or contains some other additive, because in terms of the economics, you can cut a drug supply to sell more of it and make more money. And when people have less disposable income and when people are hurting more, you've got to figure out a way to stretch your supply. So people's drug supplies are all kinds of gross and dirty, and they call it stepped on right now. But people are dying from overdoses because of fentanyl, not a heroin problem in Kane County. So we decided to design a program in the Kane County Jail. We worked with Dr. Holtzford and Lighthouse. The jail came to us. We had to merge with their medical services. So Dr. Holtzford actually took over the primary care for opioid use disorder for all the individuals that we were dealing with. The jail already had a contracted medical provider. We stepped in and provided supplemental assistance for that. And so, let's see, and put all this together. Okay, so candidates come in, they're usually coming in a state of withdrawal, or they're identifying that they do have some kind of substance use disorder. We are trying to capture them with as wide of a net as possible to get everybody help while they're in there. And if they're already in custody, we're giving them information about what our programming does. We now have a whole housing unit. You would probably refer to it as a cell block, but we have a whole housing unit in the Kane County Jail. It's called Recovery Pod, that is dedicated exclusively to Lighthouse clients. And these are all men in this pod, and we do have about 20 women on the women's unit as well that we're working with now.
Nathan, how are they identified?
So they're identified in a variety of ways when they come in. Number one, if they are in some type of withdrawal or in some type of state because of a substance use disorder, they're obviously tagged by intake for us to talk to them. Then the nurses along the way, in order for Holtzford to start to administer the medication, have the medication brought to them, there's a withdrawal scale that they use where they ask basic questions about how they're feeling and their symptoms and things like that. And so then as their withdrawal increases, if they just use heroin before they got locked up, when that withdrawal increases, there's a certain threshold that they meet. The medication is introduced to control or help the withdrawal, and then we go from there. So right now, go ahead.
Do they have a choice?
Yeah, absolutely. They can refuse services if they want. But what happens when you withdraw in jail and you don't have medication is you get really sick, and you're on a concrete floor, and they give you what's called comfort meds. They give you a little bit of antidiarrheal, they give you a little bit of Imodium, whatever, some Tylenol maybe, and you're sick for days. And opioid withdrawal will not kill you, but for most people that have been through it, they'll tell you that they wish they were dead when they were going through it. So we want to make sure that people are taken care of in this capacity. All right. In the 2 years that we've been in the jail, this is just a quick graph here, returning citizen OD death, and we have these as good stats because we compare our numbers with the coroner's office. We've actually seen an 89% decrease in death compared to the 2 years prior to us working in there. That can be attributed not only to the counseling that we're providing in the setting. We do follow-up work with them in terms of follow-up counseling at no charge to the individual. And also Dr. Holtzford continues to see them for their medications when they're released. A big component of this is we're also giving everybody that is released Narcan. And I'll talk about that in a little while too. But this is an overdose reversal drug that we can talk about, and we can actually come and train any CASA volunteer in how to use this. And so I'm just going to breeze through a couple more of these things here because I know we're kind of running out of time. So I want to make sure I get to a couple different things. So anyway, what we're doing in there works. And as we're using good data to try to find out why, but it's at this point in time, and we're trending again for this year to have at least the same type of data coming out of this year as well. And as you see that, as we reduce the deaths coming out of the jail, we are directly impacting the county deaths because the bulk of these people come in and out of the jail anyway. And so we're on a downward trend, and we are hoping it continues. Even coming out of the pandemic, we're seeing some pretty good data so far. In the jail, what the work that we're doing in there is it's increasing jail safety. Assault on staff are down, assault on detainees are down. Overall in the jail, because people are acting differently to try to come into our program, they have to earn their way in. On our pod in particular, we have had 0 staff assaults in 2 years, which is incredible. And we've actually reduced, on our pod specifically, we've reduced the inmate on inmate violence by 96% over the course of 2 years. This is what Recovery Pod looks like. The couple of guys that aren't in orange are the ones that, work for us. But you see me in the middle there, Dr. Holtzford's in the back left, the sheriff's in the top right, and Sydney, who's one of our counselors as well, is in there. And this is just a couple of them. We cooked Christmas breakfast for them. We went in and had Christmas with them. We did the same thing with Thanksgiving. We're trying to treat these men and women like human beings, and we're trying to get them to a place that they can trust us that we will continue to help them. So this is just what the pod looks like. There's a gentleman, if you see me in the middle there, immediately down from me and to my right, he was the one that died last year coming out of our program. It's a gentleman named Joseph. And as soon as he was released, his mother passed away, and he completely disconnected himself from all services, and he passed away about a month later from an overdose. The work that we do in Recovery Pod, that's me in the middle back when I had a ponytail there, the sheriff in the background. That's the lieutenant governor sitting here. We've had the lieutenant governor come in, as well as other lawmakers come in and talking to the detainees for them to help educate what they're doing and why it works. What we are doing and why it works from my perspective, we're allowing these individuals to form safe attachment in this program. It's unheard of to get locked up in Kane County, state of Illinois, or the United States of America and feel safe in the place you're incarcerated. I alluded to this earlier. We talk about trauma. Trauma can be chronic. Trauma can be something that continues on. And being incarcerated is one of the most traumatic experiences that you can go through. Think about being away from your children. Think about not only that, but understanding that what you did is the reason that you're separating your family and influencing your children perhaps to follow in your footsteps. When they're in there, they're of that sober mind. They're getting that counseling. They're coming to terms with that and working really hard to become different people. We use CBT or cognitive behavioral therapy as an umbrella, but generally speaking, it doesn't work in this type of arena, in this type of setting. We pull from a variety of different treatment modalities. We pull from motivational enhancement, values-driven lifestyle. We do some DBT work. Something that we kind of unearthed from the 60s and 70s is also logotherapy. There's a guy named Viktor Frankl that wrote a couple books. One of them is called Man's Search for Meaning. And his whole basis in therapy states that we need to find purpose and meaning in our lives. Frankl was a Holocaust survivor and survived the Holocaust by finding a way to wake up every day, even as he's watching his family murdered, finding a way to wake up every day with purpose. Because at that point in time, if you had strong mind or a strong back, they kept you alive. And so he had to find a way to stay in that mindset. He developed a therapy mode after that. And so we pull from that a little bit.
Nathan, one more time on that book title. You're a fast talker, so
I'm sorry, and I got 5 minutes left, so I'm trying to get done here. So it's called Man's Search for Meaning, by Viktor Frankl. And that outlines his experience in the Holocaust and what he's kind of developed as his mindset for therapy moving forward. Right now, a huge component that we are using is also trauma therapy. We have a trauma specialist that's working with us. She's doing EMDR trauma therapy as well as just generalized group work with me. And that has had a huge impact on the individuals that she is working with. We talk about accountability. One concept that we always use is the huddle versus the game. Even though they're getting treatment with us, they're getting services through us, they're still not to the starting line yet. They are going to go home eventually. And what is the work that continues when they're actually out playing, when they're actually in there? So to follow up and to finish up here, why do we do it? Because number one, it works. All the programs that we're using in there have been shown to work. It's been shown to work in decreasing death. It's been shown to work in increasing safety, reducing recidivism. It works. These individuals treat each other differently. They treat themselves differently. They treat their families differently when they go home. Number two, to get up on a moralistic soapbox, it's our job. It's every single one of us. We have this job. And I'm speaking to a room full of volunteers, so I know that you feel something similar. But we have to do this work. If we don't do this work, what ends up happening is the same thing that's happened over the course of the last 100 years, where people who are louder and less informed will always make policy and will always lead us down a road that's controlled by money or special interests. We have to have people like you, and we have to have people like Dr. Holtzford, who's like single-handedly changing the medical community in this area, and Sheriff Hain and Jamie Mosser, who's just been elected as our state's attorney, to have progressive vision with how to help these problems, not how to punish people, not how to incarcerate, but what to do with them so they don't return to this and their kids don't meet me in 15 years. Where do we go from here? This is Haynes' thing, what they're doing in the jail. We're treating mental health, addiction, and as well as a lack of opportunity. We have 36 job sites currently that are working with us that are ignoring background checks that will take our people right out of the jail and put them to work. We're also working with the Department of Corrections, who doesn't do a single thing to help us, but we're attempting to work with them. They are, without question, obstructionist in our efforts right now, but we're trying to work with them to get them to bring people back to county after their sentence so we can get their heads right, get them medicated, get back into the street. So that's kind of the ball game for what I wanted to say. And I'm sorry I zipped through a lot of that, but you know, Holtzford just, he talked about 2 books for 25 minutes and I need some time to say something. I can't see him. Is he laughing? Hold on, let me get out of my screen here. All
He is laughing.
All right. I don't know
So
how
we
to
do have a
stop
question.
yeah. I don't know how to stop sharing my screen, so I'll let you figure that out for me. Oh, there we go.
Nathan, we have a question. Casey
Wait.
had her hand up.
I think you answered it about the job. I was wondering what happened as far as employment afterwards. Is that on all levels, professional levels, for those who have been incarcerated who have professional level jobs versus service types of jobs?
Yeah, so that's a great question. We have some individuals, one woman in particular, she was a dental hygienist before she became addicted to the medication that they were using in the dental office, and eventually became addicted to heroin. And this woman can't get that job back in that field right now. But what she is able to do is establish work history through, we've got her set up with it's a higher level factory job. So it's not what she was doing. There's so few fields that'll just take people back in like that. So what we're trying to do is just start them back in the workforce, get them some work history, get them something on their resume instead of a blank spot for 2 years where they have to discuss incarceration. So right now, most of the jobs we have are service oriented in terms of factory labor, that kind of thing.
Thank you so much for that question, and thank you for both for this presentation. It's been incredible, and I feel like we could listen to you both for another hour and a half. That was fantastic. Thank you for allowing us to record it. It will be available password protected to our volunteers to rewatch, which I will be doing, as well as anyone who didn't have the opportunity to watch it. And I hope you both agree to come back again. Thank you, everybody, for joining us. That was phenomenal. Have a great, great day.
Thank you very much.
We appreciate it. Take care.
Bye.
Thank you.